We're all human, and it's important to know that doctors are people too. Doctors have emotions, they have passions in life and hobbies, and they enjoy participating as active members in the communities where they practice medicine. Doctors have families, friends, and relationships, while the latest in healthcare and the most current treatments for ailments will be topics on this Doctors Are People Too radio TV show. The focus will be in learning more about the interesting aspects in a physician's life and what they do away from the doctor's office or operating room table.
Good evening, South Florida, and thank you for joining us today. My name is Patty Villa, and with us tonight we have Dr. Sosa, who's the medical director at North Shore Medical Center. Good evening, Dr. Sosa.
Hi, how are you?
How are you doing today?
Very well, thank you.
Good. It's great to have you on the show once again. You gave us so much information the first time, and we just wanted to follow up with you this time around because we know you have some new interesting information that you want everyone to know about. But first of all, you know the show is called Doctors Are People Too. So I wanted to ask you, how did you become a bariatric surgeon? Because I know that this is not only what you did way back when.
It was an interesting story. I was a trauma surgeon. I was actually trained as a trauma surgeon, and I worked at the trauma center at Jackson Memorial Hospital before I came out into private practice. And I actually started doing bariatric surgery almost, not exactly by accident, but almost, I just went with some friends to a course they were having at the university. I wasn't supposed to be part of the course. I wasn't supposed to be really, learning. I wasn't all that interested. They had just told me, hey, come watch this new advanced surgery for weight loss. Because before that, bariatric surgery, weight loss surgery, was always done with a very large open wound. And it was very high risk, and the patients many, many times did not do well. They spent a week or two in the hospital, had very high complication rates. So it's not the type of surgery that ever interested me because it was so high risk. But the new approach was laparoscopic or minimally invasive, using the small incisions and the TV cameras that I was used to using to treat other problems, and we were using some in trauma. And I went and I saw 4 or 5 different surgeons performing it. And there was one particular surgeon who was just amazing at doing the operation laparoscopically. And it really, I was like, this is an amazing way to do this very, very big operation. And the results that started coming out with laparoscopic surgery was just so much better. And so at that point, I said, you know what? I think I would be good at doing this operation. Let me train. Let me do it. Let me try it. And that's how I started doing it. And then, so I was mostly a trauma surgeon doing trauma calls at that point, I had moved from Jackson to a level 2 trauma center up in Delray. But I started doing some bariatric surgery. And the need is such, and the number of patients was such, that in less than 1 year, my office was just packed with patients wanting bariatric surgery. So I gave up trauma. And I always tell people, the philosophical change is, people that came in with trauma, whether they were hit by a car or whether they were shot or whether they had a stab wound, it's almost always a tragic situation. Many times you save the patient's life, but most of those patients remain either injured or traumatized, and by no means were they happy after surgery. Many were relieved that they had survived, but they had severe injuries. And so it was, yes, you were saving lives, but the patients were not very happy. And the story I always say is when I started doing bariatric surgery, not only were we saving lives, the patients were now very, very happy with their new lives and their new health and everything. So, yeah, I totally changed the practice that I was doing, and I dedicated myself pretty much to bariatric surgery.
No, and I'm really glad that you shared that story with us because I wanted people to know a little bit about your background. And you mentioned the word being happy, and that you talk to so many people, you have so many different patients. How many surgeries have you done to date?
Well, I started in 2001, and since then I've done over 6,000 of the various bariatric or weight loss surgeries. So I have over 6,000 patients.
And how many, what I wanted to focus on this evening was a few of those success stories that you have. Why don't you share? I know we talked last week about different success stories and different people because you treat people of all different ages, all different sizes, all different heights. So why don't you share with me your first testimonial that you want to talk about this evening?
Well, as we were talking, and it was like, what is some of the most important things to highlight about weight loss surgery? And the key message that I always want to get to people is we used to think that people got sick with diabetes or high blood pressure or high cholesterol, and then they became obese. But now it's very, very clear that it is the obesity that causes those diseases. And it is the obesity that if we can fix and we can get rid of, many of those diseases get better or go away and completely return people to a more healthy, functional life. So, and the particular disease that I find most interesting and most of the people in the field find most interesting is type 2 diabetes. Type 2 diabetes in the U.S. has become a horrible, horrible epidemic. And a lot of times people are like, oh, is it a viral disease? Is it, is it our foods? And it ends up being quite simple. Obesity causes type 2 diabetes. Now, some people are genetically predisposed to getting it at a lower level of obesity. Some people have a much higher level of obesity before they get the type 2 diabetes. But obesity clearly is the cause of the type 2 diabetes. And so when you go to your doctor and they say, well, you're 70, 80, 100 pounds overweight and you're diabetic. So let's treat your diabetes. So they put you on medication, they put you on insulin, they put you on all sorts of things. But the real treatment, the real cure is to get rid of the obesity. Now, that's very difficult to do. So even if your doctor tells you, I'm treating your diabetes, I'm trying to get your sugar under control, hey, and you need to lose weight. Well, most patients that have gotten to that level of weight can't lose it on their own because there are certain changes in the brain, there are certain metabolic chemicals that make us very hungry. So getting in a diet that's going to help you lose 60, 70, 80, 100 or more pounds is very, very difficult. The fascinating thing that we found is when we do weight loss surgery on these folks and they lose the weight, their diabetes goes away. Their sugars become normal, what we call the HA1C, hemoglobin A1C, which is how we track the blood sugars are doing, become normal. So people argue whether you call it remission or cure, but the bottom line is the diabetes goes away and the horrible damage that the diabetes does goes away. And so those are the patients that I wanted to touch on today.
Well, let's talk about the first patient. But before we do that, I just want to remind our callers that if they want to call in and they have a question for Dr. Sosa, they can call 888-565-1470. So let's talk about that first patient that you wanted to all the listeners and viewers to know about.
So this is a middle-aged lady who, at this point, her diabetes had been around for about 10 years, and she was about 120 pounds overweight. So about 120 pounds over her ideal weight. She was already on very large doses of insulin. They had tried all the other new medications, Januvia, and the diabetes was sending her into kidney failure. So what we call the creatinine, or the way we measure how the kidney is working, was already significantly high. And so her doctors told her, what's going to happen is within 3 to 5 years, you're going to go into complete kidney failure. And at that point, what happens is you have to go on dialysis. And that is sadly the end of many diabetic patients, that the diabetes slowly damages the circulation of the kidney, slowly causes kidney failure, and the patients end up on dialysis. Well, dialysis is a very terrible existence. Basically, you have to go to your dialysis center 3 to 4 times a week. You have to sit on a machine that filters your blood, sometimes 2 hours, 3 or 4 hours, and you constantly attach to that machine. And unfortunately, it requires vascular surgery in your arms, sometimes even in your legs, because you run out of what we call fistula access. They get infected, they get clotted. It's a very, very difficult existence. And after several years, sometimes 10, sometimes 12, sometimes less, the patients with dialysis end up having severe organ damage, cardiovascular disease, heart disease, and most of them end up dying quite young. Whereas you expect the life expectancy in this country to be in the 80s, these folks are dying in their 50s and 60s. So, her point to me was, this disease is killing me. I know it's a big operation, and I know it's somewhat risky, but I want to do it. Now, if you look at the risk of bariatric surgery, because of the laparoscopic approach, we have actually dropped the risk quite low. So the risk of a major complication runs around 3% or 3 out of 100. And the most important risk, obviously, which is the risk of death, runs around 0.3%. So 1 out of 300 patients has a complication of the dial. Compare that against a very bad type 2 diabetic who is headed towards dialysis. Most patients say, you know what, I'm going to take this very, very small risk. And she, within 2 months of having surgery, had lost about 30 pounds, but most importantly, had normal blood sugars, which is shocking when somebody's been running sugars of 300 to 400 for 2 or 3 years on really large doses of insulin. All of a sudden, on no insulin, only a pill, they're running normal blood sugars. It is, no one can believe it. It is shocking. The patient can believe it, her endocrinologist, her primary care physician. I see it all the time. And our society has well published it, and now the American Diabetic Association has come out with new recommendations that bariatric surgery should be considered what's called a first-line therapy for type 2 diabetics that are difficult to control or are having significant complications of diabetes. Short of the story, at the end of the year, she loses 100 pounds. It's only about 15 to 20 pounds over her normal ideal weight. Either whether we call it cure or remission of diabetes, it's gone. So she has normal blood sugars and doesn't take any medications for them. And obviously, her renal or kidney function starts to normalize. It stops getting worse, but more interestingly, it starts to get better. So some of the diabetic damage starts to go away from her kidneys. So if she continues on this course, then we would expect her life expectancy to go back towards the normal life expectancy of anyone her age. And that's one of the fascinating things about obesity surgery or weight loss surgery. It's not just to get people to lose the weight. It is to get rid of the diseases that the obesity is causing, and making them go back to a healthier lifestyle that then is going to allow them to live the length of life they were supposed to.
Exactly. We're going to take a short break right now, but when we come back with you, Dr. Sosa, I want to continue talking about some success stories that you have regarding people that have come to you that have diabetes. And I want you to mention some of the important things that we should know about from the articles that you emailed me this past week. We're with Dr. Sosa. We'll be back in a moment.
Hi, my name is Dr. Rahul Agarwal. I'm an interventional cardiologist in Jupiter, Florida. I did my medical school at the University of Florida and my internship and residency at the same program. I did my chief residency also at Shands, and then did my cardiology and interventional cardiology at Wake Forest University in Winston-Salem, North Carolina. I specialize in general cardiology, interventional cardiology, and nuclear cardiology. Even though I'm an interventional cardiologist, the majority of my practice involves general cardiology. General cardiology is a pretty broad spectrum in that it involves rhythm problems such as atrial fibrillation, heart disease such as coronary artery disease, congenital heart disease, high blood pressure, and cholesterol problems. I do procedures such as cardioversions, which involve trying to convert the patient back to a normal rhythm if they have an arrhythmia. Also deal with plumbing problems such as the coronary arteries, which if they're blocked, I can do angioplasty and stents, which involves balloons that open up the arteries. And these stents act as scaffolds that keep these arteries open. I really do believe in preventive medicine, and one of the areas that I really focus on is diet. One can really get caught up on the pills aspect and the exercise. And diet we talk about a lot, but unless one really has some guidance as to where to go with diet, it can be quite difficult. So I do give my patients homework in terms of books or movies that they can rent or obtain so that they can get educated. Our cardiology office is located in the Abacoa area of Jupiter, Florida, conveniently located between 2 of the local hospitals. We provide echocardiography, stress testing, ultra monitoring, and general cardiology office visits. We really pride our practice in its staff, who are very courteous and professional. We believe that under our care, you'll feel the same way too.
You are listening to Doctors Are People Too with David DiPino, who shows us the human side of medical doctors in the community. If you have a question for our guest, call into the show at 888-565-1470. Now, let's get back to the fun side of doctors and show that they are people too.
Good evening, South Florida. My name is Patty Villa. I'm filling in for the fabulous Dave DiPino, who's off this evening. And with us tonight is Dr. Sosa, who's the medical director at North Shore Medical Center. Dr. Sosa, we were talking about diabetes and how bariatric surgery can help people with diabetes. Can you share with us another story, a success story of a person that you've been able to help?
Sure, certainly. So diabetes causes not only kidney problems that we talked about, it causes circulatory problems to the small blood vessels of the legs especially. So a lot of diabetic patients get what we call diabetic neuropathy in their legs. They get vascular disease in their legs, and it's very hard for them to walk. And it gets to the point when if the diabetes gets severe enough that they essentially can't walk, often end up losing a leg, a foot, amputations because they get bad infections, etc. But a patient that was already developing diabetic foot ulcers, diabetes was way out of control despite significant medications, and the patient was referred for that to see if weight loss surgery could get his blood sugars under control. Now, it's very interesting because something to point out is there are different types of weight loss surgeries. A very, very new popular operation is what we call the sleeve gastrectomy, which is a really, really good operation. It has low complication rates, low side effects. Usually it's very good for losing about 70 to 80 pounds. So the patient comes and says, well, I want to get rid of my diabetes. I need to lose about 70 pounds. I want a sleeve gastrectomy. And so the fascinating discussion is, okay, the interesting thing, though, is the sleeve gastrectomy is not such a good operation for diabetes. So some patients with the sleeve gastrectomy lose the weight or lose a significant amount of weight, but their diabetes still doesn't go away. When you compare that to the gastric bypass is way, way more effective at eliminating diabetes. There's a lot of research going on now because we don't quite know what the big difference is. Now, in the operations, we know a huge change happens. In the sleeve gastrectomy, basically all we do is we remove about 80% of the patient's stomach. But the way the food goes from mouth to stomach to what we call duodenum, small bowel, and colon is the typical normal way. It's just you now have a much, much smaller stomach, so a much smaller meal fills you and satisfies you, and you can't overeat. In the gastric bypass, though, we make a new little stomach that we connect directly to the intestine. The old stomach's there, but it's sealed off. Now, the interesting thing is, with the gastric bypass, the way you eat now, the meal does not go the normal, quote-unquote, route. The food does not go by the duodenum, by the area where the pancreas secretes the hormones and the proteins that help digestion. And so what happens in patients who have gastric bypass is their sugar absorption, not just their meal size, but their sugar absorption massively decreases. So gastric bypass patients basically cannot eat sugar because they won't absorb it. And so when they eat sugar, let's say, they decide to have a little bucket of Haagen-Dazs or whatever, the sugar is not absorbed by the body. Once that sugar gets to the colon, the bacteria work on it, and what happens is the patient gets a lot of bloating and a lot of diarrhea. So although the patient can put the sugar in their mouth, they're not actually ingesting the sugar because it just goes right through them. And so the gastric bypass pretty much eliminates the diabetes, probably not just by decreased food, but by the fact that you can no longer absorb sugar. Especially our diets are very high in refined, simple sugars. The U.S. has one of the highest consumptions of sugar in the world. And that's why we think the obesity epidemic and the type 2 diabetes epidemic is so bad in the U.S. Now, this operation not only helps you lose weight, it makes you not absorb all that sugar that's in the corn syrup and in the sodas and in the, sweetened cereals. And if you basically no longer absorb all that sugar, when your body's not faced with all that sugar, your diabetes goes away. Now the insulin you normally produce is good enough to maintain your blood sugar levels normally. And those patients immediately get better. The sugars come down. They stop damaging those blood vessels to their legs. The neuropathy stops advancing. They lose the weight. Now they begin to walk. They begin to exercise. The circulation starts to get better. And you take a patient that was almost wheelchair-ridden, and now you have this patient speed walking around the park doing several blocks. And I joke with them that now they're in better shape than I am. So the surgery can have remarkable effects, especially in folks with diabetes, because it's such a terrible disease.
It is. It is. Dr. Sosa, I know that you give conferences, you give lectures, you're in the media, you're in the spotlight, just educating everyone in our community and around the world. Tell us, what else is it that you tell patients about diabetes and what they can do? Because as I mentioned, you emailed me these very interesting articles, and I just want to pick your brain so you can share with our listeners and our viewers what you took away from reading these most recent articles regarding being overweight and diabetes.
Well, let's quickly divide diabetes into two. There's type 1 diabetes, which basically you're kind of born with, or you get very, very young when you're, less than teenager. And that's a defect that your pancreas just does not make insulin or enough insulin, period. And so those folks will always need outside insulin, what we call exogenous insulin or outside insulin that we as physicians give them, and they inject themselves either with a needle under their skin or with an insulin pump. So those folks are different. Those is type 1. That really has no cure with obesity surgery. They're trying to develop a cure with pancreas transplants, pancreas islets, transplants, etc. So we'll put type 1 aside. Let's talk about type 2. Type 2 diabetes is your pancreas is there. It's making insulin. But for your level of obesity, the level of fat that you have in your body, the fat deposits, you create what's called insulin resistance. So now, no matter how much insulin your pancreas is trying to make, it is not enough to maintain your levels of blood sugar normal. So the sugar in your blood gets high. Now, those high levels of sugar in your blood is what damages all the organs. That sugar shouldn't be high, but it is. So it goes to your eye, and it damages and causes diabetic retinopathy or eye damage. It causes blindness. It goes to your kidney, and it causes kidney damage. It goes to your nerves, and it causes neuropathy or nerve damage. It goes to your blood vessels, and it causes atherosclerosis. So we got to get that sugar down. Now, we can either give you even more insulin than you're already making, but you're making normal levels of insulin. And the more insulin we give you from the outside, the more resistance you get. Or we can decrease your fat stores and eliminate what we call the insulin resistance. Now, a super, super strict diet can also accomplish this. The problem is most patients cannot maintain those super, super strict diets year after year after year. There's some resetting of the way we eat, the hormones that make us hungry, that those diets in our society are very, very difficult to maintain long term. Weight loss surgery, though, gives you a tool that it prevents you from overeating, and with the gastric bypass, prevents you from absorbing sugar. So at first, the endocrinologist, the American Diabetes Society, the AMA looked at bariatric surgery and diabetes, and they were like, well, we think it was, but we're not sure. But now, the articles you're discussing is the new recommendations after looking at multiple studies of weight loss surgery or gastric bypass in type 2 diabetics, and basically the results are outstanding. Most people have significant improvement of their diabetes. Most or all get off insulin. Many go into cure or remission. The vast majority, over half of them, get no more diabetes, no more medications. So now multiple societies, including the American Diabetic Association and other societies that deal with diabetes, have come out and made a formal recommendation that if you're morbidly obese or your body mass is over 35, you have type 2 diabetes that's difficult to control or beginning to show some complications, you should consider weight loss surgery as what's called a primary treatment modality, that it can be used to as the first choice to control the obesity, eliminate the obesity, and get rid of the diabetes. And this is the first time such a national recommendation has come out saying weight loss surgery should be considered as a first line of therapy, choice line of therapy for type 2 diabetics that are morbidly obese. And so we think we're going to be able to help a lot more people with the surgery that are suffering from diabetes and obesity.
Okay. And I know that you give lectures at North Shore Medical Center the first Thursday of the month at 7 p.m. And I have seen so many people come into your lectures to hear you speak and to hear you educate them on the subject. But what is the number one question that you get month after month from everybody that comes to see you?
Well, I mean, obviously, everybody's concerned, and it rightly so, should be, okay, how risky is the operation? How risky is the operation? As a funny joke, everybody asks me, the more brave, forward people walk up to me and say, okay, what are my chances I'm never going to wake up on the table? Well, that's never happened. Everybody's always woken up on the table. Yet, there are some people who do develop significant complications, and so there is some risk. And so, okay, how risky is it? Well, you have to put it into some perspective. For example, it's not nearly as risky as having cancer surgery or major colon surgery or open heart surgery, but it is slightly riskier than having your gallbladder removed or a hernia repaired. So, but if you do use the numbers, the risk of a complication is about 3% or 3 out of 100, and the risk of dying from a complication of weight loss surgery is about 0.03%, or 1 out of 300 patients will develop a significant complication. If you look at those statistics, and there are big national and international studies that have been done, that risk is way, way less than the risk of death from remaining morbidly obese and a bad type 2 diabetic. And that's why the surgery is now recommended as a first-line therapy.
And what about those people that are feeling hesitant of coming to listen to one of your lectures or coming just to your office and talking to you? What is it that you tell those people?
Well, what I tell them is this: learning will never hurt you. So come learn. The interesting statistics is this: when a person first considers to have weight loss surgery, till the time they decide to have it, it usually takes 8 months. So I tell people, just come and listen. You don't have to even decide. You just come and listen. You begin to learn the information. And then sometimes people use that as a motivation to try further diet, further exercise. But they have this tool available that in the future they may use it. And it takes about 7 or 8 months for most patients to decide, you know what, I am going to do the surgery. And that's the statistic that the studies show. So I always tell people, come learn. We do a seminar, it takes about 2 hours, so we talk about everything, all the operations, all the results, all the risks. They get to meet patients who've already had the surgery. They get to meet our team. And then no one says to you, well, you want to do it? No. We just say, okay, thank you, good night for coming. And then you go think about it, and you keep learning about it. It may be right for you, or it may not. You have to, it's a very personal decision that every patient has to make.
That's right. And, the show, I asked you how you got into bariatric surgery, but just to know a little bit about you, because I've heard you say that story, and I love that story about how you went from being a trauma surgeon to a bariatric surgeon. But the show, as I mentioned, is called Doctors Are People Too. I know you mentioned that you like to dance. You love to go eat with your lovely wife, Christy, who I've gotten to know and is absolutely always so helpful. What did you do this past weekend, and how has your summer been?
Well, the summer's been very, very busy. I've been working a lot. I don't currently have a partner. I'm looking for one. So if a doctor out there wants to be a bariatric surgeon and join my very busy practice, let me know. So we took staycations, which I guess a lot of folks are doing. We took a few staycations. We have a 6-year-old who's just about to be 7. So between his karate camps and the staycations are a busy summer. This particular weekend is back to school weekend. So we spent it preparing to go back to school. It's a major event for a 6-year-old, as you can imagine. So, but it went smoothly today, fortunately. He loves his his school, his new classmates. Everything was good today.
Oh, that's fantastic, because I was going to ask you about that. Well, thank you for joining us, Dr. Sosa. And I just want all our listeners to know that if they want to come to a lecture at North Shore Medical Center, they can call 1-800-984-3434. 1-800-984-3434. Dr. Sosa, before we continue on with Dr. Bayer, is there anything else you would like to add this evening?
No, it was a pleasure. Thank you.
Thank you so much for being with us, and thank you so much for serving our community. We'll be right back.
I make a dinner for me and my girlfriend. We ate, we enjoyed. The dinner was very good. She was ready to go to sleep. I said, okay, I'm gonna stay on the couch a little bit to watch TV. I started to feel something in my throat, like I was choking, and all of a sudden I feel the pain, the sharp pain, like somebody put a knife in your back and open and do like this. That was when I called my girlfriend. I said, you have to take me to the hospital. I couldn't die. When they were doing the test, they saw something was weird. My valve was ripped. I said, God, please help me to get out of this. Dr. Bayer was on call. He was who performed my surgery. I described like an angel. I described like he was there to do that for me. My girlfriend, my son, he told me when they saw him getting out from the operation room, he was sweating. He was tired to be there for 10 hours. For me, it's unbelievable. I can walk, I can exercise a little bit, and I can drink red wine, that light red one. Of course, 1 glass or 2 glasses. I see the life different. And I want to see my granddaughter to grow and my son to get old. So I wanna live. I think that God gave me one more chance in life, and I had to take advantage of this.
You are listening to Doctors Are People Too with David DiPino, who shows us the human side of medical doctors in the community. If you have a question for our guest, call into the show at 888-565-1470. Now, let's get back to the fun side of doctors and show that they are people too.
Good evening, everyone. My name is Patty Villa, and I'm filling in for the fabulous Dave DiPino, who's off this evening. Tonight, I have with me a special person, a man that has become a good friend, Dr. Eric Bayer from Florida Medical Center. Good evening, Dr. Bayer.
Hey, Patty, how are you?
Good. How are you doing?
I'm doing great.
Well, I was in a meeting last week with Trey and LJ, and they were telling me about the symposium that we have coming up in September. And I want you to tell our listeners and our viewers a little bit about that.
Yeah, it's a symposium about atrial fibrillation that we're going to be doing, and you probably have the location.
I do.
Okay,
I'm
good.
going to let
good.
everybody know where it's going on.
Perfect, because what we're going to be doing is going out and speaking to the public. Dr. Kenningsberg and myself, he's an electrophysiologist.
That's okay. We know you're a busy man. This happened last time.
I'm going to turn this off. I apologize. And the thing is what we're going to be talking about is atrial fibrillation, which is a very common problem that is throughout the world, actually, and it's a rhythm disturbance. And what we want to do is really just educate the public on this disease process. And atrial fibrillation, afflicts many millions of people in the United States. And it's one of the rhythm problems where the atria are basically quivering. They're not contracting normally or relaxing and contracting. They're just quivering. And that can create a whole host of problems. So that's what we're really going to be focusing on at these conferences and these meetings. So.
Can you take us into like the day that you're planning? Because like you mentioned, I know Dr. Kenningsberg is going to have a part, and he's working, with you, and you guys are working more and more together. And I really like listening to all the stories. And also Dr. Nairi is going to be there too.
That is correct. So Dr. Nairi and Dr. Kenningsberg are both electrophysiologists. So they're cardiologists by training. And I am a heart surgeon by training. And what we have found is over time that atrial fibrillation, this problem that we're talking about, is treated very well by multiple modalities. In other words, it's good to have an electrophysiologist on board and a cardiac surgeon on board. And the interesting thing about atrial fibrillation is that AFib can be kind of short bursts of AFib, so people can have it and go in and out of it. And some people sense they're going in and out of it, and it can be quite dramatic, and it kind of scares them, and they get anxious. And then there's some people that have it kind of chronically. AFib is a problem that starts out in that early phase where it goes in and out, and then eventually it goes in and out more and more, and then eventually you kind of stay in atrial fibrillation. And what Dr. Kenningsberg and Dr. Nayari really focus on are the people that are what's called paroxysmal atrial fibrillation, which is when you go in and out of the atrial fibrillation, and where the two specialties meet is more in the persistent, or what we call chronic persistent atrial fibrillation, where people are more or less permanently in atrial fibrillation, and that's where I come in. And so what we'll be talking about is the pathology of atrial fibrillation, what the causes are of atrial fibrillation, what it does to you, what the complications are of AFib, and then we'll talk about the different treatment therapies together.
No, and what I think is really interesting is that this affects everybody from all different ages.
Yes.
And I think, if you can tell us a little bit about that.
I'll tell you a little bit about it. It doesn't affect as many young people as it does older people. As you get older, the likelihood of you developing atrial fibrillation increases. So what we see is in people, rarely do you see somebody in their 20s with atrial fibrillation. It can happen. But as you get into the 40s and 50s, you start seeing more and more atrial fibrillation. The incidence of it goes up. And then certainly as you age into the 80s, that incidence just keeps climbing. And the big problem with atrial fibrillation is that it can cause strokes. That's the big deal. And if you're ever watching television at night or watching the news or anything, or, I'll be sitting, watching sports even, and there's always commercials for these blood thinners.
That's right.
Out there.
I see them.
Pradaxa and Eliquis and all of these commercials that are out there. And really those drug companies have focused on, preventing the complication of atrial fibrillation. They ask, do you have AFib unrelated to valve disease? They'll always say that in the commercial. And then if you have that kind of AFib, you're a candidate to be on one of those medicines. And those medicines are really to thin your blood out, and they're not they do a great job of preventing strokes, but there's a downside obviously to being on a blood thinner. You fall and hit your head, and you can get a brain bleed, or if you get in a car accident, or you're riding your bicycle around and fall, the problems of bleeding become apparent. And so our focus is on curing atrial fibrillation, actually curing it, fixing it, or also dealing with the complications of it, such as the stroke complication, and having people come off of their medicines. I've taken many people off of their blood thinners and their antiarrhythmics over time, because what we do is once we treat it, we find that we've cured their AFib, and then we can go on and take them off of their medications and monitor. Obviously we monitor them very closely. But like I said, I've taken many people off of their antiarrhythmics and their blood thinners.
Let me just mention, because I want everybody to grab their paper and their pen. I just want to let them know when, the symposium is going to be.
That'd be great.
Friday, September 16th at FMC, and that's in the auditorium. And it's at noon, and there's going to be a light lunch served.
That's right.
And if you want to call and make a reservation, you can call 844-246-7846. And then on Tuesday, September 27th, it's going to be at the Westin Fort Lauderdale. And the address is 400 Corporate Drive. And that's going to be at 10 a.m. We're going to serve some refreshments there. And you can call 844-246-7846 for reservations. And I am going to mention that once again. So if you didn't get it this time, before the show ends, I will mention it again. I'm not going to go to commercial tonight because I really want to ask you so many questions. I know that you're working on several interesting cases with Dr. Kenningsberg. I was on the phone with him several times last week. Can you share a little bit of what you're working on lately?
Well, what we've been doing is there's a lot of things that we've done together. Kenningsberg is very innovative, relatively young electrophysiologist.
And he's a very good communicator,
He's a great communicator. That's what I really love about
and you and
David.
him have great energy together because I've seen it.
Yeah, in fact, tomorrow evening we're flying out together to Tampa to go to a cadaver lab, believe it or not, and we're actually going to be looking at devices that help clip this atrial appendage to get people off of their antiarrhythmics, and we're actually going to be on one of the first groups to actually use this device that's been developed by AtriCure, and so that's kind of, we are constantly trying to get onto the cutting edge of treating atrial fibrillation. But that's the nice thing about working with somebody you enjoy working with, you respect their work, and I think his feeling is mutual for me, and so it's nice when we get together and we really, we tailor the therapies to individually to the patients. And so, there might be somebody who's had a couple of ablations before, and they'll come to Dr. Kenningsberg, and he's never seen them, and an electrophysiologist has done that, and they're still an AFib, and he will recommend, coming to see me and talking to me about the different therapeutic options that I offer. And we always, try to work on getting the best therapy for the patient, individualize each therapy, and that's the nice thing about working with somebody who's got an open mind like that.
Yes, no, that's fantastic, and I really like seeing the energy between both of you, because that's very important when doctors are communicating.
That's right. Yeah, and at these symposiums, it's going to be great because we'll all be there, and it's nice seeing us and how we communicate. And we may not agree on everything, but we always at least try to come to a conclusion that makes sense for the patient and takes into account the patient's needs. And the other thing is while at the symposiums, a lot of people come in and then they have a lot of questions afterwards. So we try to leave a lot of time to kind of talk individually with people that come in that have questions about their atrial fibrillation or any arrhythmia that they have, and we try to answer any of those questions while they're there, and we'll sit down and talk with everybody until they're done asking questions. So,
and that's what I wanted to ask you. I mean, we're promoting the symposium that we're doing in September. Florida Medical Center is hosting it. For those people that are at home or they're listening to us this evening, if they have a doubt about going to the symposium, what would you say to them? Why they should go?
Well, I think they should just go just to educate themselves on this problem, and that's the big thing. Is like, it's so great having these experts be able to talk to you about exactly what's going on. And this disease process is very confusing. A lot of times people go into the doctor, oh, you've got AFib, and we're going to put you on this drug, and we'll see you later. And what we want to do is educate the patients and family members on what this disease process is, because at the end of the day, unless you educate yourself on what's going on, you don't know really what the therapeutic options are. And so I think that's really what we want to do. We just want to educate everybody and make it entertaining and interesting, and then answer questions afterwards. That's really what it boils down to.
And Florida Medical Center is so much on the cutting edge. I mean, they are always doing lectures, and they're always trying to educate the community. When you go and you give all these different lectures, because I've seen pictures, and I've been with you on a few of them.
Yep.
What is the question that you get asked the most?
Well, I get a lot of great questions, and afterwards it's always fun sitting down and talking to everybody, because they'll ask me, listen, my doctor, wants to put a pacemaker in me, or my this doctor wants to put me on this drug, and I don't feel well on, and so there's a lot of different questions that we get that we hope we can help answer and guide people into the right form of therapy. But like I said, a lot of these drugs that these patients are on are they can bring patients down really where they don't feel well, and they may not know why they're not feeling so well. And if we can find a way to get them off of those medicines, it often benefits them tremendously. In fact, Dr. Kenningsberg sent me a couple of patients that we've operated on, and they were one patient had 9 ablations up in I won't say where, but north of here, and we brought them in and devised a therapeutic option for them. They went with it, and we performed a little mini access maze procedure on them. And I tell you, a year later, they're just they're feeling great. They're off their medicines, and they tell me all the time how great they feel, and they got a new lease on their life. A lot of people think they're just getting older, and that's why they're feeling tired. But really, it's these medicines and the disease process that can cause a lot of the symptoms. And so once we get them off the meds, it's like a new day for them. There's another gentleman that also had inferior vena cava filter in and could not have ablation. So that's where I came in. Again, we tailor everybody to the form of therapy. Some people just can't be on anticoagulation medicines. They've had a hemorrhagic stroke in the past, or they've had a GI bleed in the past, and their doctors won't let them be on anticoagulation. And those patients are really good candidates for this left atrial clip, and to have a ablation, some sort of form of ablation therapy, and try to get them out of the AFib. Well, then there's some patients that are on these medicines, and they block their heart rate so low that they have to get a pacemaker, and they're just at a loss. And so there's just a lot of questions that we get when we're at these symposiums that allow us to kind of completely answer patients' questions.
And let me just mention the information one more time. Sure. Friday, September 16th at Florida Medical Center, and that is going to be in the auditorium. Light lunch is going to be provided, and that's at noon. And please call 844-246-7846. Then on September 27th, you can see Dr. Byer, Dr. Kenningsberg, Dr. Nairi once again, and that's going to be at the Westin in Fort Lauderdale, 400 Corporate Drive, Fort Lauderdale, 10 a.m., light refreshments, and you can call 844-246-7846. You were last with me here on the show a month ago.
That's right.
And what has been the most interesting case that you've seen in this last month?
In the last month,
I know you see so many, because I was with Trey last week in a meeting, and Trey is the CEO for Florida Medical Center, and he's just doing a marvelous job with his A-team. And he was telling me I talk to Dr. Byer every day, several times a day. There's always something going on. So what's been the latest and greatest from Florida Medical Center?
Well, we are doing a lot of minimal access valve repairs. In fact,
he was telling me that.
Yeah, I did one today. We've got a couple on there on Thursday. Got a couple of big cases on tomorrow. These are all big open heart surgeries that we do there. And, I tell you, it's every day in South Florida, there's always something new and exciting, I have to admit. And, the cases don't get any easier. It seems like, as I've gotten older, I've been doing this for about 12 years now, after my training, 12 years. And it's I tell you, there's a lot of complex cases out there. But certainly, I did a case the other day. I did a double valve maze, which is basically treating atrial fibrillation in a patient that has two leaky valves. And when you did it through a very small incision on them, they did very well. Got out of the hospital in about 5 days, and they just they're back on their feet and doing well. And those are the things that we're used to dealing with, and we deal with all the time.
And the show's called Doctors Are People Too.
That's right.
And I want to ask you a little bit about your personal life, because I know you were born and raised in South Florida.
That's right.
So if you could tell me a little bit about how it was growing up in South Florida.
Man, I love growing up in South Florida. I've told you this before, but growing up in South Florida was wonderful because the weather's so great. Obviously it's hot now, but I kind of like the heat, but in the winters are great. What I really enjoy the most is going out and trying to catch a few fish. In fact, on Sunday morning, we went out with a friend of ours. I've got a friend of mine in from Germany, actually, and
he's with us this evening.
He's here in the studio with us, and he's leaving tomorrow. But he's been here for a week, so I try to get him out fishing on Sunday, and we went out and had a great time. We didn't catch any fish, unfortunately, but it's just nice getting out on the water. And living the lifestyle that we live down here. I really enjoy it. And I have a 5-year-old son that and just every day there's so many things to do, whether it's going to swim lessons or playing soccer and just getting out. It reminds me of my childhood where I was able to get out and go fishing and just be outdoors a whole lot. And that's what I enjoy. I enjoy being down here because there's a lot of things going on. So it's a lot of fun.
And how has your summer been? Because before you were on this evening, we had Dr. Sosa, and he's told us that he's been so busy that he's had to take his staycations here.
That's right.
How has your summer
been? My
been?
summer's been great, actually. I've had great friends come in from Germany. My mother's German, and so I speak German. And I've met a lot of good friends along the way who are from Germany. So it's nice having them come down and enjoy the sun. And then when I go there, I get a visit with them too, and it's a lot of fun. So, but the summer's been wonderful, just absolutely fantastic.
That's awesome.
Yeah.
That's awesome. I wanted to ask you, when did you know that you wanted to become a doctor?
That's a great question. My mom always tells me that I just told her, when I was like 3 or 4, I wanted to be a doctor, and I never really let go of that actually. So from a very early age, I wanted to be a doctor. I remember going to the library when I was like 5 or 6 in near Cutler Ridge Mall there, and there was a library, public library, just pulling out books on surgery and on medicine and just getting into it. And ever since then, that's all I've ever wanted to be. And I didn't know really I wanted to be a heart surgeon until I moved to Houston, Texas. And in Houston, I did my general surgery. And of course, there's all these great kind of legends in cardiac surgery there. Michael DeBakey, who's now deceased, Denton Cooley, and I was able to have direct contact with them, and was able to really get into the history of cardiac surgery and get to meet these people and learn from them. And so that's when I developed an interest in doing open heart surgery. And, I just had a passion about it ever since then. It's just been something I've been very, very interested in. So.
And where did you go to medical school?
I went to medical school in Tennessee. We moved from Miami when I was young to Memphis, Tennessee. I was 13 years of age when we left Miami because my dad took a job with Federal Express there.
But nobody really knew what Federal Express
nobody knew what it was in
at
1980.
the time.
Yeah, it was a very small company at the time, but he made the right choice. I actually talk about this. I couldn't believe.
And I love that story.
Yeah,
I love when you share that story.
Yeah, he's taking a job with a company that sends boxes overnight somewhere. I was like, no, this is never going to fly, And of course, I was wrong. But my dad did very well there, and he retired there. My parents both live in Memphis. Obviously, they come down here quite a bit. My sister lives in Cocoa Beach. I live obviously here in Fort Lauderdale, or nearby here in Fort Lauderdale, and so they come and visit a lot. Hopefully, they'll move down here eventually again. I know my mom loved living down here. She still has a lot of friends that live in Miami, in the Kendall area, and the Cutler Ridge area, and Coral Gables. So we still see them actually up until this day. My mom was on the phone with one of them yesterday, actually.
And Dr. Breyer, how do you manage your time? Because you are so busy. Every time I call you or text you or send you an email, he's like doing 3 things at once. He's like the magic man. So how is it that you just pull it all together?
Well, I try to prioritize what I'm doing and then be organized about it, and then try to be as efficient as possible. It's nice when you have administration also on your side at the hospitals, because they allow you to be more efficient and come up with ideas of being more efficient. Because, it's really important that you spend time with your family, too.
Yes.
I get as much time in with my son as possible, my wife. And so, when we do things, we get out and have fun. But it's so easy here. If you live if you live somewhere else, you have to go on vacation to go have fun here. It's just in your backyard, basically. So.
And you mentioned something that's very important, and something that I've learned in the last 9 months that I've been working in the healthcare industry as well, is that you need the support from administration, from that A team. Tell us a little bit about the relationship that you have with the A team, because the other day I was mentioning to Trey, well, I talk to Dr. Byer on a weekly basis, and he looked at me and he goes, well, I talk to him on a daily basis several times a day.
That's about right.
We kind of joked about that. So tell me a little bit about the relationship that you have.
That's the best thing about Tenet is, whenever, I need to go speak to Trey, our CEO, his door is pretty much open. And, there are things that pop up from day to day that we communicate about. And then we have long range goals, medium range goals, and of course there's short term goals. And, if there's ever any ways to make things more efficient or to increase patient satisfaction, I'm always looking for those. And I certainly listen to the patients when they're in the hospital. I mean, they're my absolute number one priority. So, when they come to me with a problem or an issue, I have direct access to the CEO, and things get taken care of immediately. Fortunately, it's very, very few and far between that we have issues, but it's nice having that access rather than just kind of shrugging and saying, well, I hope things get better. But that's the nice thing about it, is having that direct access and then kind of unleashing the force of the administration on what we need to do to improve. and that's always our goal, is always keep improving. There's never going to be a day where we're going to be satisfied.
That's true. And, and just so everyone knows, I mean, we meet on a monthly basis as well, a big
right.
team of us, just to discuss, cases and different things, outreach for the community, and just having those relationships with other doctors, which is so important.
That's right.
Tell us a little bit about that, because you're the one that leads those
Yeah,
meetings.
that's right. Those are great meetings, and the fact that it's just like you said. I mean, we try to get out to the community. I mean, if patients are in your community, don't stay in the community, that's a real problem. So I think that's the most important thing, is really making connection with the community, making connection with your patients and with the referring physicians. But also, we really focus on quality. And what we do is there's this thing called the SDS National Database. And that's one thing that I really pride myself on. We focus on. We want to meet or beat the national standards for doing cardiac cases.
And let me just mention, because we only have a few minutes left, but let me just mention this one more time, because I want everybody to really write this down, because I've gotten to know you. I've gotten to know Dr. Kenningsberg and Dr. Nairi. We've been working on projects together, and they're just so have so much knowledge to share with the community. This is something I feel passionate about as well, educating people on different different things that they need to learn about in the medical medical field and in healthcare. So once again, we're talking about with Dr. Beyer our symposium that's going to take place next month, September 16th at FMC in the auditorium. It's going to be at noon. Light lunch provided, and please call 844-246-7846 for reservations. And then September 27th at the Westin Fort Lauderdale. Please call, and I'm going to repeat this number for the last time, 844-246-7846. Please come and meet Dr. Beyer. He's a phenomenal person.
It's going to be a real relaxing
phenomenal doctor,
yes.
And all of you are going to really learn quite a bit that day. Thank you so much, and good night.
Thank you, Patty.
Thank you for listening and watching Doctors Are People Too with David DiPino. Join us next week for more in-depth views on what doctors are all about and how they spend their free time. All shows can be seen on amp2.tv. And if you have questions you want answered on the air, call 866-224-5422 and leave a message that can be read on the air. The opinions expressed on the preceding sponsored program were strictly those of its hosts, guests, and callers, and not necessarily